All right, good afternoon, and thank you for the opportunity to present this topic. I have no disclosures. So feeding tubes are fairly common procedures that we do nearly every day, all right? And when they go well, I mean, we kind of barely stop to breathe a sigh of relief, but gosh, when they go poorly, the results are often disastrous for our patients, as these videos and a picture from one of my own cases shows. So these complications can be extremely morbid, they can be fatal, and they can significantly impact our patients' ability to heal, their ability to undergo cancer treatment, if that was the indication for the feeding tube, and their ability to have adequate nutrition, which was kind of the whole purpose of the procedure to begin with. So we'll spend a few minutes just kind of quickly reviewing the types of tubes that are out there. We'll focus on really two emergent complications, dislodgment and necrotizing soft tissue infections. Talk about how to approach these situations in the OR or in the endosuite, and then lastly, talk about how to prevent these complications in the first place. So just a quick review, these are kind of, hopefully they show up okay. These are the most common feeding tubes that you'll typically see at the hospital. Some of them won't have a balloon on the end. These are the most common. Oh no.
Feeding tube fell out.
Feeding tube is out. What do we got?
Pause.
It's hilarious that our screens work.
Our screens work, so we'll
Yeah, our screens work. Should I just wait? I assume they're coming up. Okay. Sorry, everybody. It sounds like it's like dead, actually.
There was an audible sound too when it went
There,
Yeah, there was a sound, yeah.
I probably touched.
Oh, there we go. Wow, saved. Awesome. Yeah, truly. That's an MVP move. Well done. So these are the most common feeding tubes that you'll typically see at your hospital. Some of them will not have a balloon on them at the end. These are the most common ones that you'll see when you're actually placing a PEG tube. Some of them will have a balloon. You need to make sure that the balloon works, obviously, before you put it in. And then you have these low-profile tubes that do come with extensions, and sometimes these are more comfortable for the patients, especially in your patients that are able to move about. They're out and they're discharged or outpatient and dealing with these tubes. And then there are some similar options for jejunostomy tubes, although there are also even smaller jejunostomy tubes that can really limit the amount of drainage that these patients experience. But the main point here is that you should know what your hospital carries. You should look at it, you should look at the tube, make sure you know how it works, so you can hopefully mitigate and prevent any complications. So after you've placed your tube successfully, there are some complications that may land you right back in the OR or the endosuite. We'll first just talk quickly about the management of early dislodgement. So that'll be most of our technical consideration section as well. It occurs in about 1 to 4% of tubes placed, and the important thing to remember is that the tract that we create during the procedure, that begins to mature within about 7 to 10 days, but it can take up to 6 weeks, and that's why some people actually still consider it early dislodgement if it happens within a month post-procedure. The incidence of early dislodgement and late dislodgement actually is pretty underreported. But when these tubes come out, it's not only a significant healthcare burden in terms of hospital resources, hospital costs, it's obviously a significant risk to the patient because now they have a free perforation of the stomach or the jejunum to the abdominal wall, and the consequences of that can lead to mortality. Switching gears to necrotizing soft tissue infection, while these only occur in about 1% of patients with a feeding tube, when it occurs, the results can be devastating and often fatal, which is why we wanted to highlight them. Typically, this occurs due to leakage of enteric contents into the abdominal wall when the tube is dislodged. Typically, that tube is under a lot of tension, which you can actually see in this picture right here. And you can actually see in the CT scan that there's been some leakage of the contents in between the muscles and then also into the subcu space. And so risk factors for necrotizing soft tissue infection are going to be diabetes, obesity, and then this can occur in your elderly and non-mobile patients. And in this particular patient in the picture, they had the first 3 risk factors. So definitely keep a high index of suspicion for necrotizing soft tissue infections. All right, so the tube is out, or we realize that we may have a necrotizing infection. Now what? Well, in the case of dislodgement that really hasn't led to a necrotizing infection, I think you have options as long as the patient's stable. If the patient's unstable, then you're headed to the OR for either a laparotomy or hopefully we can convince you to try the laparoscopic approach. If they're stable, you can take a deep breath and then, as I tell the residents, get curious. So if the tube is partially out, you can get a contrast study through the tube. And then if it's in the stomach, it's your lucky day. You just deflate the balloon, advance your catheter, I would secure it to the skin, and then of course, shoot another contrast study to make sure that it's in the correct position. If it's not in the stomach, as we see in this contrast study here, you still have some options in terms of your approach, but the tube obviously will need to be replaced either endoscopically or surgically. If the patient's stable and your tube has been completely removed, as I said, you still have the same options pretty much as the previous slide. If they don't have peritonitis or focal peritonitis, which is subjective, you can just decide to decompress the stomach with an NG tube and then consider endoscopic replacement. If they have focal peritonitis, you can perform a contrast study, and how you do that in these patients who've lost their access. If they can swallow, you can do an upper GI. But most of these patients have dysphagia, so many times you'll just need to get a CT with PO via the NG tube. And so, of course, if your contrast study is positive for a leak, then endoscopy and laparoscopy are still on the table as options. So focusing on laparoscopy first, I think in general we've accepted that the laparoscopic approach for many surgeries results in positive outcomes, even in emergency surgery. And so in this patient population in particular, we really want to avoid wound complications. So if you don't feel comfortable tackling this via endoscopy, definitely try it lap, even when it looks like this. This was an IR tube that was placed, and you can see the T-fasteners kind of came down, the stomach fell away, and then of course all the spillage. And so Dr. Teitelbaum was kind enough to give us this video. And so what he's doing is just kind of going in and debriding and clearing off the stomach. Of course, he's gonna suction out all the debris, and then he's just gonna actually repexy the stomach with sutures to the abdominal wall. I did put on the bottom some suggested port placements that you can think about when you're approaching these patients. This is about the port placement that we use for our laparoscopic G tubes and J tubes at my institution. And so if you have a problem and you need to go back, I would recommend starting with these ports. And of course, 5s are always free, so you can always add more ports as you need. I'll just let the video go a little bit longer so you can see him just kind of pexing at least one portion up to the abdominal wall. Again, it's not gonna look pretty, but you just need to get that stomach up there and then suck out as much of the contamination as possible. All right, so lap if you can, but I would also say that if you have the support for it at your institution, give endoscopy a chance as well. It is a safe alternative. Here's a great study that came out last year with a video that hopefully we'll play that I'll show in a sec. This is from Dr. Pauly and colleagues. It was a multi-institutional retrospective analysis that looked at about 11 patients with early dislodgement. The most common cause of the dislodgement, of course, was the patients pulling on the tube. The average time from dislodgement to PEG rescue was about 8 hours, so not necessarily something that you had to go right back for. The mean procedure time was about a little over an hour, and most of these were performed in the OR, with only one being performed in the endo suite. So you're going to the OR anyway, so you can always just think, I'll try it endoscopically, and if it doesn't work, then my next steps are laparoscopy or a laparotomy. And then, of course, excellently, there were no complications in this group. So hopefully this video will play. I'll just let the authors talk and they'll narrate, and then I'll highlight some of the points afterwards.
A 5.4 millimeter slim gastroscope is advanced per oral to the stomach using low volume CO2 insufflation to avoid tension pneumoperitoneum from translocation of gas across the gastrostomy tract into the abdominal cavity. The prior gastrostomy site is found in the anterior gastric wall and is directly traversed with a small caliber endoscope. After traversing the tract, we see the anterior abdominal wall and liver. The prior cutaneous tract is cannulated with the introducer sheath to aid in identification. In this case, a biliary lithotripsy basket was used in place of the standard PEG snare to grasp the PEG exchange wire. From this point, a standard pulled PEG placement can be performed, with the addition of gastrointestinal T-fasteners to further secure the gastrocutaneous tract in the event of a second inadvertent dislodgement.
So I'm not sure if all that audio came through, but I think the key points were, one, when you're doing this, you want to have low volume CO2 insufflation so you avoid tension pneumoperitoneum. You want to go through the gastrostomy with a small caliber endoscope. Once you're in there, you can actually irrigate and you can suction any spillage. It's not going to be as extensive as in the previous video, but you can suction any little spillage with the endoscope. And then you want to consider T-fasteners to avoid, God forbid, a repeat dislodgement. All right, so just lastly, shifting gears back to necrotizing soft tissue infection. So this is a true surgical emergency, so immediately you're gonna be heading straight back to the operating room as soon as you have even a suspicion that this is what's going on. These patients are gonna need aggressive surgical debridement. You'll likely need to ultimately resite the feeding tube. You don't have to do that during the initial operation. Your priority should be taking out as much of the dead area or the affected tissue as possible. But eventually, you'll probably have to resite it because there is normal leakage that occurs with these tubes, and that's gonna get in the way of these wounds healing. I don't want to end the talk without discussing prevention. So just remember that minimizing complications is going to begin with proper planning and prevention strategies. Given the risk that's going to be associated with these tubes, we should be having a thorough, informed consent conversation with our patients or the patient's caregivers if they can't make decisions for themselves. And then we got to look at these tubes daily and give education to our nursing colleagues, give education to our internal medicine colleagues who are going to be taking care of these patients once we sign off, just to make sure that we minimize these tubes coming out sooner than they need to. Abdominal binders can be great to prevent the tubes from being pulled by patients and then by moving around. And then of course we can place a mesentery on the tube so that if the tube is pulled, it's really only being pulled externally, not internally. And then just some closing points. So planning and prevention are key to preventing disastrous complications. In situations of dislodgement, you want to gain more information in stable patients with a contrast study. And then once you have your contrast study, if the tube is out, just remember the laparoscopic and endoscopic approaches are safe. So try them if you have support at your institution, and you may need to partner with your gastroenterology colleagues as well, particularly with endoscopy. And then lastly, have a high index of suspicion for necrotizing soft tissue infections in high-risk patients, and they're gonna need aggressive debridement for treatment. Thank you very much.